Okay.
All right. Thank you all for joining us today. Today I'm going to talk about the various uses of technology in forensic mental health practice. So before we dive too much into this topic, I want to just draw some distinctions about different areas of practice. So first, forensic practice and clinical practice. So those differ in a lot of different ways, including how we conceptualize or understand who our client is, what the purpose of the service is, who the information can be disclosed to, lots of other areas as well. And then we're also differing today between assessment practice and then conducting treatment and interventions with clients. So the different kind of quadrants you can consider in this area. There's different ethical and practical considerations in all of these quadrants. Today, we're going to focus mostly on the forensic assessment and forensic treatment intervention piece. All right. Okay, so the main topics we're going to address today are the practice of telepsychology, which I'll get into what the definition really is and what is included in that in a minute. How we decide or what the ethical implications are about searching for clients on the internet. And then how internet and social network data can be incorporated into forensic evaluation. Again, that distinction will be important. So first, to talk about telepsychology practice. So the American Psychological Association actually did produce guidelines on this topic back in 2013, so predating the COVID pandemic even. And they defined telepsychology as very broadly in terms of the provision of psychological services using any form of telecommunication technology. So again, this is super broad, and it includes even just like telephone sessions, telephone being used to even schedule sessions or do collateral interviews, using mobile devices like texting or FaceTime, things like that. Video conferencing like Zoom, GoToMeeting, using email, chat, text messaging, and then even on the internet with social media, blogs, other various websites. So what do these guidelines really say? And so the first talks about the competence of the psychologist, and that is, and actually, let me just make sure you guys are seeing the slides or the presenter mode?
The slide.
Okay, good. I just want to make sure. I realized I didn't check. Okay. So competence of the psychologist. So what's outlined here in the guidelines is that providers really should be ensuring their own understanding and competence related to both the actual technology used and understanding the potential impact of using this technology with clients. The second guideline put forth is that ethical and professional standards of care must be the same when providing telepsychology than what is used in providing in-person services. So those APA guidelines, those ACA guidelines, all of those professional standard guidelines, you need to consider those as well when you're using telepsychology. There's differences in informed consent, and really what's the APA is saying here is that the informed consent should explicitly address telepsychology. And so any of those facets, potential things that I'm going to talk about in a second about confidentiality, data preservation, all that sort of thing, that all needs to be expressed explicitly in your informed consent. So these next three kind of go together, but this one, the confidentiality of data and information, this is saying that clinicians must protect the confidentiality and data of information related to client care and inform clients of any potential increase in risk of breach of confidentiality due to the technology. Security and transmission of data and information. It's again in the same vein. Providers must take reasonable steps to ensure that there are additional security measures in place to prevent unintended disclosure of client data and information. Again, understanding that there might be a higher level of risk with technology rather than, you know, paper pencil, housing things in a locked drawer, that sort of thing. And then the third one that kind of goes with this is disposal of data and information technologies. So electronic data must be disposed of in a manner that prevents unauthorized access to this information. So if you're on a networked computer, for example, you can't just drop something in a recycling bin that other people might be able to access. You need to be able to delete that securely from a computer. For psychologists, there's special considerations that need to be had for testing and assessment, particularly when the testing measures that are being used were standardized on an in-person population. So providers are urged to consider the unique aspects of providing these services through telehealth platforms. And then lastly, the use of telepsychology does open doors to providing services across borders of states, even nations and continents. And so providers must be familiar with whatever jurisdiction they are providing treatment in, those local laws and practices. They must know those in addition to where they are physically, where they physically are and where their client physically is. Okay, so how is telepsychology being used in practice? So again, this is very broad. Mostly, especially post onset of the pandemic, video conference treatment evaluations is very common, using Zoom platform, DoxyMe, that sort of technology. Providers are also integrating mobile apps into in-person treatment. So there's a lot of apps out there that are like symptom trackers, for example. And so providers are integrating that into their practice. There's also the controversial mobile apps for text therapy, things like BetterHelp or Cerebral, where you are matched with a provider, you never meet in person, you never see face-to-face, but are texting them. Even as basic as telephone calls for follow-up information for scheduling, telephone calls for therapy sessions. A lot of providers these days are using text messaging for scheduling as well. And again, since the onset of COVID-19, remote psychological test administration has increased quite a bit, and I'll cite some research about that in a second. And I'm sure there are so many other ways that telepsychology is being integrated into practice, but these are just some examples. So the question became, especially at the beginning of the pandemic, what does the research say about telepsychology? Is this effective? Is this something we should be doing? Obviously, when COVID started, there was a necessity for it. But at the same time, just because there's a necessity doesn't mean we shouldn't be making sure we're grounded in good practice. So some research has come out, especially since COVID has begun, about the use of telepsychology. And so, of course, as we, it's pretty obvious, this is increased drastically since then. On average, prior to the pandemic, only about 1/3 of forensic practitioners endorsed using telepsychology. Telepsychology probably was even less prevalent in the forensic realm as compared to the clinical realm prior to the pandemic, given all of the facets in terms of needing it to be admitted into evidence in court and making sure those standards are followed, and just having the ability to see a client and making sure that there's no outside influence on evaluations. That said, though, that number, 30-something%, jumped all the way to 92% of forensic practitioners saying that they began using telepsychology, or they were using telepsychology during the pandemic. Prior to the pandemic, people were using this mostly in terms of reaching rural communities or distance evaluations for that due to location issues. But of course, that shifted during the pandemic to needing to use this kind of technology to protect health and safety of both clinicians and clients. Trainings on telepsychology also increased tenfold during the pandemic. This is not an area that is talked about very much during graduate school training or even during continuing education, but has become such a necessity since the onset of the pandemic. Again, the forensic test measures has been slower to grow, but still quite a bit of growth, where 4% of forensic practitioners endorsed doing this pre-pandemic, all the way up to 38% during the pandemic endorsing using forensic test measures via telehealth platform. So does this work? I know we're doing it because out of necessity, but is this sort of model equitable to providing these services in person? So several studies have addressed this, and this specific report was a meta-analysis of a lot of different studies regarding the use of video conference technology for behavioral health services. And in some, they found no significant differences between in-person services and video conference services. And so this included a meta-analysis of 43 studies about interventions that showed similar pre and post intervention symptom reduction as per the client's own report. And then another meta-analysis of 14 studies about assessment using video conference platforms. And this showed that scores were similar on assessment measures when they were given in person and when they were given in telehealth. So again, in general, we're not seeing significant differences in using telehealth versus in-person services. Other studies are showing that this is equivalent and to services rendered in person, which is really great to see, especially since a lot of us were sort of forced into doing that when the pandemic started. So what are some things that clinicians should think about prior to using telepsychology in practice in general, but also with specific clients, because you're going to encounter clients that are good for this modality and some that aren't. So here are some things we want to consider. So first, right off the bat, the appropriateness of the client for this modality. So these recommendations are also from the APA. They put these forth in March 2020, right after the pandemic started. And so at this point in time, they suggested the appropriateness of the client for the modality as something to be looked at. Things like ensuring clients have access to the technology they need, ensuring clients have a private space to conduct a session is also imperative, but then also considering the client's cognitive or clinical presentation to ensure that they have the cognitive ability or the ability related to their clinical presentation to actually engage and use this technology. For example, you might encounter somebody with an intellectual disability who does not have any support, who can help, and they don't know how to use the technology. You might also encounter somebody with a thought disorder or psychosis who has an intense paranoia about technology. They're probably not the best to do a evaluation over the computer with. Another consideration is what sort of technology are you going to use? Clinicians need to ensure that the platform they're using, whether it be Zoom or Doxy.me, anything like that, is HIPAA compliant. There's a business agreement in place, and then also that it's secure in any other way. And then also providers need to ensure that both their and clients' internet are stable, and that the client knows how to use the technology, and they know how to use the technology as well. The location of sessions is also an important consideration, just as it would be in in-person appointments. So sessions should be occurring in a private, reasonably quiet space on both provider and client's ends. Providers should consider the lighting of their room that they're in, the audio, the picture quality that they have, how is their camera angled even, and what's showing in their background. Providers also need to prepare their clients for the session. So discussing the risks and the benefits of telepsychology with them ahead of time, creating a backup plan should there be a disconnection of their connection, or if there's a crisis as well, knowing where that client is. And then gain informed consent through a secure platform. So a lot of times when you see a client for the first time in person, they're signing all these forms. How are you going to get those through a secure manner when you're not going to meet this person in person? In my practice, I've utilized Adobe Sign. Other clients have used, or other providers have used, like things like DocuSign, secure email platforms in order to maintain privacy and confidentiality. And then the last consideration is that at the outset of session, there's a lot of things that you want to provide as disclaimers and just kind of set the session up. So you want to verify a client's identity. If you've never met them before, you might need to ensure that who you're speaking with is indeed the person you're intending to meet with. Confirm where the client is located and get a phone number for them if you don't have already. Again, this is important in case of a crisis, especially, but also in the event that the connection is disconnected. And then reviewing the importance of privacy. So this includes not only talking about being in a private space with nobody else around, but also providing a disclaimer that either side will not be recording the session without consent. This is something especially important when administering psychological test measures to ensure that there is not any breach of that secure information about a test. Okay, now that we've talked about telepsychology in general, let's talk about something that comes up frequently, especially in training, about searching clients on the internet. So in general, this is unfortunately not explicitly discussed or addressed in any of our relevant practice guidelines or standards, including the APA Ethical Code, the American Counseling Association Ethical Code, and the Specialty Guideline for Forensic Psychology. So the literature does put forth some suggestions, some guidance. A lot of literature refers to this specific behavior as patient-targeted Googling. And the research shows that in general, majority of psychotherapists haven't considered this topic and have not looked up their clients online. And when therapists have endorsed engaging in patient-targeted Googling, it's typically related to concerns regarding self-harm or potential of a threat to others by their client. That said, though, this comes up often enough, and we're all on social media, that it is, I think, becoming a more and more common ethical dilemma, and it's worth discussing at this point and also integrating into our education and training. And so this is kind of supported by this last study listed here, as far as psychologists in training were surveyed, and a quarter of them responded that they had Googled clients at least once. Or at least one of their clients they have Googled. So what do we do? How do we make this decision if there's no ethical code to guide this? Well, like I said, the literature has put forth some suggestions. And Clinton et al. From 2015, it was mainly created for psychiatrists, but in a therapy setting. And so it can be extrapolated to not only a general therapy setting, but a forensic therapy setting. So that's kind of the framework we're looking at here, is for therapists, how to consider this. So Clinton's framework consists of a total of 6 questions, 3 of which the clinician should ask themselves before they engage in the patient-targeted Googling, And then 3 questions to be asked after they do it if they decide to. Overall, this should be considered on a case-by-case basis. It encourages just clinicians to have a concrete decision-making process before making this decision. The framework takes into account just general moral principles in addition to, what as therapists we might have as practice standards. It does also allow for the possibility that searching for a client may aid the therapeutic process, which I do think is a shift in literature because, or the thoughts, I guess, of therapists, because had we discussed this maybe even 10, 15 years ago, it'd be a hard no. No, you do not Google clients. But it also seeks to then minimize the risk of harm and exploitation of the client. All right, so I'm going to take you through the framework now, those 6 questions. So the first question you want to ask yourself is, why do I want to conduct the search in the first place? And in order to kind of come to a conclusion about this why question, the framework encourages therapists to use consultation or supervision to discover and discuss their different motivations for conducting the search. And it also helps consider the possibility of self-deception, meaning that the person's not being even truthful with themselves. So that's why it's helpful to talk this out with a trusted peer or supervisor or consultation person. So in the event that through all of this consultation and supervision and self-reflection, a clinician discovers inappropriate motivation, that's stop, do not proceed, go directly to jail, not really, but go if you were playing Monopoly, do not pass go. And then it does though allow for, okay, let's say that in this thought process, there is a belief that the search is in the client's best interest. Again, going back to the research saying that a lot of times when this has happened, it's related to self-harm or threat of harm to others. And so perhaps that will give you critical information to prevent something terrible from happening. So let's say that that's what happens. The framework says, okay, you're not ready to search just yet, go to the next question. So the next question to consider is, would my search advance or compromise the treatment? Again, recognizing that a therapeutic relationship, regardless of if it's in a forensic or a clinical setting, but a therapeutic relationship is different than a evaluator relationship. And so there are different levels of trust that go along with that. And so in order to consider this question, clinicians, therapists should predict information that might be obtained that would promote the client's best interests and help and guide treatment, predict what kind of information might be found that would threaten the therapeutic relationship, and also considering what sort of validity of the content you would get through your search. Okay, and so in doing all of that kind of pro-con list, if at the end of all that, the clinician therapist still believes that the information, or if the clinician believes that the information obtained will not advance treatment, could harm the treatment, or there's an alternative way to get that information without having as much of a risk. The framework says, again, stop, do not proceed, do not pass go, stop there, don't make the search. If in the event though, however, after considering all these areas, the therapist feels like the information they obtained might help advance treatment, would it necessarily predictably harm the treatment or therapeutic relationships, and also can't be obtained in any other way, then the framework says, okay, we're good so far. Let's proceed to the last question before you make the search. So the third question to consider is, should you obtain informed consent prior to searching? Should you notify your client before you do this or not? So consider how seeking their informed consent might preserve their privacy and enhance the therapeutic relationship. And in considering this, if you think that your client would take offense to learning about the search after the fact, The framework says, at a minimum, seriously consider obtaining informed consent prior to the search. And then if you're obtaining informed consent or you have this discussion with the client, depending on that outcome, then you could proceed to the search and then ultimately to question 4. If after deliberating this, it's kind of unclear whether the client would take offense, but there's a high likelihood that beneficial information would be found and a low likelihood that the client would be offended by finding out about the search after the fact. This model says, okay, the search may be justifiable without consent. Go ahead and then proceed to question 4 after that. And then lastly, if it's unclear if the client would take offense, but there's a low likelihood that there'd be beneficial information discovered and a high likelihood that the client would be offended, this is the stop, do not pass go. Don't seriously consider not doing the search. And at that point, potentially all the way proceed to the last question, which we'll go over in a couple minutes. Okay, so between question 3 or 4, what happens is, depending on these outcomes here, the clinician, the therapist will do the Google search or whatever kind of search you're going to use. So after the search happens, if that's what the outcome is based on this framework, the therapist should consider whether they should share the results of the search with the client. So in trying to answer this question, clinicians should consider how to use the information in a clinically, or how to use the information clinically, and whether to disclose it based on the nature of therapeutic relationships. So if in examining this, they think about, okay, this is clinically useful. It's something you probably want to discuss with the client. It would further treatment. It aligns with treatment goals. You have a fairly good therapeutic relationship where you trust each other and you feel the client would be in a good emotional state to process this, then you probably are determining that the search could be disclosed. And in that case, disclose the search, consider consultation and how to go about that, and then proceed to question 5. If in considering all these facets, you determine that the search should not be disclosed to the client, carefully consider potential effects of the non-disclosure on the therapeutic relationship. There's a kind of phenomenon talked about secret keeping in terms of a therapist having this secret, and what does that do to a therapist's relationship with their client. And so in that sense, again, seeking out consultation and supervision would be very helpful. And then proceed to the next question to kind of further examine, this post-mortem of the searching. So the next thing to consider is should the fact that something was searched and the findings of that search be documented. So first, as we teach our students, as forensic clinicians know, documentation is key. If it's not documented, it didn't happen. And so it's very important to document all relevant clinical information accurately. But at the same time, you need to anticipate that a client or another provider may access this document. So some things to consider. So if sensitive information was discovered in the search, what are you going to do about that? Should that be included? So at that point, if there was sensitive information discovered in the search, you're going to want to consult with an attorney about the appropriate course of action. But at a minimum, you need to document that the search was conducted. And then after all this, we're going to still continue to this last question for the rest of the process. If there is no sensitive information discovered, or even if there was irrelevant or nothing important discovered, you'll document and again proceed to the final question. So lastly, and this is a continuing basis sort of question, how do you continually monitor your motivations and the ongoing risk benefit profile of making a search on your client? As with everything in our field, this framework suggests engaging in regular, ongoing, and honest self-reflection of your own motivations and emotions in relationship to cases involving online searches. If you become involved in another case that's potentially challenging and there's potential of a need for an online search, or that's a suggestion, At that point in time, you're going to consider this framework again, probably, but also consider clinical, ethical, and legal consultation, as well as engaging in self-care. Again, the point of this is to monitor your own motivations. And so there are times where we're motivated to search clients for our own curiosity or our own satisfaction or things like that. But that's not really the goal of this, and what does that mean for you as a clinician? And so really monitoring that through self-reflection in an ongoing basis is important. All right, so the last area we'll discuss today is using internet and social network data. And this is again specifically related to forensic evaluations. And for those of you not completely familiar with the nature of forensic evaluations are a trust one viewpoint because there's a lot of ulterior motives through the use or in the justice system or in the forensic evaluation system.
Dr. Belmonte, sorry, you froze there a little bit.
Yep, I saw I got an internet connection's unstable. Where did I leave off?
Just a little bit towards the beginning of the use of internet and social work data.
All right, so just to maybe I'll repeat myself, but that's okay. So before we get into this section, I just wanted to address like that the forensic evaluations are a specific kind of evaluation. And that's because we don't always, the client isn't typically the person who's sitting in front of us. It might be the court, it might be an attorney. There's a need for objectivity and unbiased viewpoints in forensic evaluation. And so you need to consider a collateral context. You need to gather multiple sources of data because everybody kind of in this process can potentially have ulterior motives. And so that's why in forensic evaluations, this is a little bit of a more specific area to address. So similarly to what we just discussed about patient-targeted Googling, there's not really any ethical guidelines to using internet and social media data in forensic evaluations. Most literature does address this. They don't necessarily address it in treatment. And again, it's not explicitly addressed in any of our ethics codes or specialty guidelines. That said, a lot of the literature uses semi-related ethical codes. They're addressing other issues such as privacy and confidentiality, use of third-party data, impartiality and fairness, informed consent, reliability of sources, and so forth. And this helps, using those adjacent ethical codes can help inform the decision to use publicly available information in forensic evaluations. But again, researchers and practitioners have identified this as an area that is needing more guidance. And so there's a lot of suggestions in the literature about this. And so again, just a reminder that there's an important distinction between clinical and forensic work. And so the Pirelli et al. Team put forth some recommendations about how to use social network data in forensic evaluations. And so when we're talking about social network data, we are talking about like Facebook, Twitter, that sort of thing, but we could also consider it broadly in terms of publicly available information on the internet. So the first recommendation that Pirelli's team put forth is that evaluators should consider internet-based data as a type of collateral information rather than a self-report information. So if you're examining an evaluator or the evaluatee is Facebook, for example, don't think about it as a direct quote from them and their self-report, but more so think about it as a collateral contact. Evaluators should weigh the potential utility of the data against the possible prejudicial effects on a case-by-case basis. We all know that sometimes people act differently in an online setting versus in person. There is a little bit more anonymity. And so we need to be sure that we're addressing potential prejudicial things that come out of social media as we decide whether to integrate this into a forensic evaluation. Whenever possible, discuss the process of data gathering and potential use of social network data with the examinee during the informed consent process. So a lot of researchers are now saying it is best to maybe build this into a consent form to really ensure that clients know that this is a possibility at the upfront. There are times too where this is given as part of discovery and part of the referral packet. And so clients should be aware that this information can be used as well. Again, when possible, share the data that you obtained from the internet with the examinees to give them the opportunity to address it. It's not always possible, but again, these are things to strive for. And then you need to be explicit and transparent about how you used and relied upon the data in your report and when you testify on a forensic evaluation. There's also some specific guidelines in terms of special types of forensic evaluation. So I'll just talk about one that I'm most versed in today, competency to stand trial evaluations. And so this it ties into our specialty guidelines as forensic psychologists, where we are implored to consider multiple sources of data because this increases our objectivity, our neutrality, and reduces our bias. The interesting thing about competency to stand trial is that competency to stand trial is in the here and now. So what does this person know at the moment about the court proceedings? How can this person behave in the moment in court? A lot of what we find on the internet is not here and now. It's happened in the past. It was posted years ago. And so there's some special considerations to make when integrating this information into a competency to stand trial evaluation. There are laws that allow this kind of data to be entered into evidence. Federal Rules of Evidence 702 is one of them. And the research shows that 63.7% of professionals surveyed use social network data in forensic evaluation. It's also increasingly included in discovery as well. I myself have gotten packets of text messages between somebody accused of a sex offense. I've gotten Facebook posts, somebody accused of domestic violence. These are things that law enforcement officials and other investigators have already obtained, and so they've provided to me at the outset of evaluations. Some things to be cautionary about. It could be difficult to establish the authenticity of social media data, and so strive to do that. If there's any doubt into did this person actually post this piece of information, it's something that definitely needs to be addressed if used, but at the same time thinking about not using that piece of information as well. And kind of what I said on the previous slide, we have to, in a competency evaluation, you have to determine whether that piece of data speaks to the defendant's true state of mind at the proximity to the competency to stand trial evaluation. If it's from 5 years ago that this person is expressing paranoid beliefs and there's no indication that this person is doing that now, that's definitely something to consider, that this piece of information may not be relevant to the evaluation at this point in time. And also corroborate your data whenever possible. And this is just even a general standard. So to wrap up, I wanted to provide some case examples when I've used social network data in the past in evaluations. The first of which was a 22-year-old white male, and he came for an evaluation while he was on probation to see what sort of treatment he may need to prevent any further recidivism. During my evaluation with him, he presented with high levels of grandiosity and paranoia. He described himself as a, quote, minor internet celebrity, and he disclosed that this resulted in him being targeted by individuals on the internet or sometimes referred to as swatting. And so he disclosed to me in the evaluation without prompting that there were news articles and blog posts written about his experience, and he encouraged me to look at the postings. And so at the time I was under supervision, and so I discussed this with my supervisor, and together we made the decision to search for the client by his name on the internet. First, because he's kind of invited me to do that in the first place, and so that was something about him giving consent already. But also we wanted to verify his statements, because there was a question about what sort of paranoia was he presenting with? Was it to the threshold of it's delusional, or was it just a subclinical paranoia that related more towards a personality disorder? And so this was helpful because we were able to identify those news articles and blog posts that he talked about to me. And we did end up, or I did end up giving him a different diagnosis, and I gave him a personality disorder diagnosis rather than a schizophrenia diagnosis as a result of finding this and being able to corroborate this information. The second example I have is a 44-year-old white female, and she presented as highly uncooperative and hostile during my evaluation with her, and this was a competence to stand trial evaluation. She refused to disclose basic information about herself, including where she lived, where her children lived, what her birth date was, what her children's names, all of these sorts of things that were very, very basic, but also relevant that I needed to know to assess her level of risk while residing in the community. And so there was also questions based on her presentation about malingering or feigning of symptoms. And so because of this, and because I was concerned about the risk level in the community where her children were living, especially, I decided with consultation to search the client on the internet by her full name. She has a very unique name, so it was easy to corroborate the information found. And I found information on social media. I found appellate court decisions that were publicly available on the internet. I found a YouTube page that she's created with her own videos that I was able to corroborate based on her, appearance in the videos. And those public court records proved especially important because they did help inform the risk assessments. They did state where her children were residing, and there was a lot of other information in there that helped me arrive at a diagnosis for her. The last example is a 19-year-old Black male who I was seeing as an evaluator for competency to stand trial, but he was also in competency restoration treatment with a provider. And so during the course of both the evaluation and treatment, there was increased concern about possible paranoia and delusions he was having about what he termed as haters online. He showed both myself and his treatment provider his phone during various sessions with social media pages pulled up, but we couldn't really see anything. He was like scrolling through it very quickly. But he would discuss regularly in treatment about how distressing that this was for him to think about the haters, to feel feel like he was being targeted by people. And then he also disclosed like he's had to block hundreds of individuals on his social media pages because of these haters. And so again, in consultation with the team, I decided to search for the client's social media. So I specifically searched on Facebook I think I started on Facebook, and found him on Facebook to assess sort of the veracity of his claim that there are all these haters out there, to just see, is this something that he's just experiencing internally, or is this a true depiction of reality? And so it was discovered that he had pretty minimal interactions on his social media pages with other people. In fact, what I was able to discover was a series of different pages under his name that he managed, both on Facebook and Instagram, where he interacted with himself. So like he would post something on one page, and then on his other account, he would like it. And so it was a good diagnostic picture of kind of showing this first break in schizophrenia for this young man, where he is experiencing high levels of paranoia. He's also withdrawing from relationships and interacting with himself. Yeah, not really having a lot of friendships where he was described as previously having a lot of friends. So all of these, I think the theme I want to highlight was all of these decisions were made in consultation with other people. There was a specific purpose for it. It was a limited scope. And these things were reported in the evaluations specifically, even in the evaluation of that 44-year-old female, included direct links even to the PDFs that I found of these appellate court decisions. So that's all what I got for you today about the use of technology in forensic mental health practice. Happy to answer any questions or comments.
Yeah, I actually do have a question. Thank you so much, Dr. Belmonte, for this. I really appreciated you speaking on the framework for doing, some sort of like self-reflection before you do that Google search of a client. And I'm just wondering if for some, especially younger generations, if it's harder to find their digital footprint, as I know oftentimes they'll use like a username that's not related to their legal name or have some sort of like online pseudonym. So just curious on like your experience with that.
Yeah, that last case I talked about that 19-year-old male, even though he was 19, he was actually in juvenile court. He was still in high school. So he presented as significantly younger than his stated age. And I was able to find his Facebook because he did have his legal name on there, and he was connected with an account that was his mom's name as well. So I was able to verify that that was his account. He also posted pictures about him. But the only way I was able to find his Instagram is because he linked it to his Facebook. Otherwise, his username I would not have been able to find through Instagram. And that's kind of why I started with Facebook, because Facebook does require you to put a actual name in. I mean, people can use pseudonyms and whatnot. But yeah, it's definitely something to be cautious about in terms of making sure you're verifying that the pages are actually from the person that you're looking for. And so I kind of cross-checked a lot of different things, like I said, in terms of photos, other friends he had on the pages, and which one was his mom. And also that he had showed his treatment provider his page, and so we were able to kind of like match it to like his profile picture to what was shown to the treatment provider.
Okay, thank you.
Yeah, great question. Any others? All right. Well, thank you or Seth, did you have a question, or we're just going to wrap up?
I was just going to wrap up, and it's pretty interesting, topic, Dr. Belmonte. I always wonder, what are guidelines and studies out there regarding, social media and diagnosing and things like that. But this is very interesting, and thank you for today's presentation.
Thank you all for being here. I really appreciate it. And I'm also happy to answer any questions if there are prospective students on the call. If there's questions about the program, happy to answer that here as well.
Yes, I've also posted my info there. If you have any questions about our program or the school, I will be sending you guys the PowerPoint. And I also, like to take this opportunity. Our next Faculty Spotlight speaker series is going to be on April 7th with Dr. Tiffany Clomax. Her topic is destigmatizing medical records. So I will send that RSVP as well. Also on the same invite would be the next one with Dr. Jason Dana.
Thank you all. I'll put my email in the chat as well in case anybody wants to email me directly with questions. But thank you all for taking the time today. I know everybody has limited time these days, so thank you very much for spending your lunch hour or whatever hour with us.
Thank you all. Have
All
a
right.
great the rest of your afternoon. Thank you,
You
Dr.
too.
Belmonte.
Bye.